All right, let me slide these boxes over. Nancy, I got your text. Thank you. And Nancy, the guy that does all the sales for New England Marine is Ralph Sanders. I'll send you his contact info if you don't already have it later. All right, so we're going to talk chapter 23, gynecologic emergencies. It's kind of a short chapter. We don't deal a lot with this kind of stuff in the field, more than we do with obstetric stuff. But we do have some that are out there that we do come in contact with. Most of the time, usually they're taken to the hospital by POV. We usually don't get a chance to actually see them. But there's still potential. So, same as usual, the National EMS Education Standard Competencies. So we have to meet the standard education competencies to treat the acutely ill patient. So gynecology is recognition and management of shock associated with vaginal bleeding. How we're going to handle this. We're going to go over a little bit of A&P, physiology, and assessment findings of the management of the vaginal bleeding, sexual assault, to include appropriate emotional support and also types of infections we're going to come in contact with. With that being said, women are uniquely designed to conceive and give birth. Right? Women are also susceptible to problems that do not occur in men. So for the newer EMTs, younger male EMTs, when they have a gynecological type emergency that they respond to, a lot of times they feel a little shy to ask the appropriate questions because they're using different wording and things like that. And they're like, oh, I really want to get into talking with this female about, the external female genitalia. So with that being said, we have to get past that anxiety and past that shyness to get stuff out to actually do our assessment. So learning a little bit more about the A and P of the external female genitalia, we have the vaginal opening, the labia with labia majora and the labia minora, clitoris, and the perineum, which is the area of skin between the vagina and the anus, as you can see in the picture here. So anus perineum is in here. If we have a labor and delivery type deal, we may have tearing through here as well. So there'll be some bleeding. But the biggest thing for us to worry about with any kind of, look at that, actually, we'll skip that for now. We'll be talking about obstetrics in the next chapter. These are just more landmarks. So we have the labia minora located here. Let me bring up my... All right. And then the urethra here. X. All right. So with the urethra, now this is something very important, especially with knowing A&P. Women are very highly susceptible to urinary tract infections. And that's just due to the urethra being such a short distance getting into where the bladder is located versus males that have a longer urethra than females do. That's why we don't see many males that have urinary tract infections versus females. So something to pick up on, especially if you have a patient with altered mental status, things that just don't make sense, and they've had smelly type urine to discolored type urine, or any kind of burning sensations when they're urinating, and things like that. If they're altered and they show signs of shock, but they're like, oh, well, I don't see a sign of infection, it could be something like a urosepsis. So just understand that the urethra being smaller and shorter in distance. Now, we're not going to go down. We're not going to inspect this area at all. We're not going to take a look at it and say, oh, how does this look? We will be letting the female tell us the issues that she's been having. Now, if there's any kind of significant bleeding down there, then we're going to have to expose and take a look and see what's going on. We don't palpate. We don't touch with our fingers. We just kind of take a look. We collect the blood and apply pads underneath as needed and transport to the hospital. The ovaries are the primary internal female reproductive organ. They produce ovum or eggs, and they also lie on each side of the lower abdomen. The fallopian tubes connect each ovary with the uterus. The fallopian tube being a very common area of ectopic pregnancies as well. Hey, Mike. All right, moving forward. There we go. The uterus is a muscular organ where the fetus actually grows. Okay, so it sits in the uterus. This is where a fetus starts to grow. It's the narrowest part of the uterus is the cervix, and the cervix opens into the vagina. With that being said, we don't look for this at all, but we have. Let me turn my phone off for you guys. All right, cervix. So we look for cervix dilation. We're not going to go down there and actually measure that, but as the cervix dilates, it gets based on centimeters, gets bigger and bigger and bigger, opening up. This is to open up the birth canal to allow the baby to be delivered. We'll cover more of that in obstetrics. The vagina is the outermost cavity of the woman's reproductive system, which forms the lower part of the birth canal. I'll close out of that. I'm supposed to be in a mandatory meeting tonight. That's not happening. You guys are way more important. All right, as you can see here, I know that is not a picture of a cow. So as you can see, the ovaries lie on each side with the fallopian tubes being here, and they connect it into the uterus, or that's where the eggs lie and the newborn starts to develop. I should say the fetus starts to develop. We go into our cervix here. We start seeing significant dilation when we have. I was reading Mike's message in the corner. Sorry. When we're getting ready to deliver, and this can take hours and hours upon hours and days to start seeing cervic dilation. Obviously, it comes through the birth canal here, through the vagina, and then delivered. Kind of a side view as well. Ovulation and menstruation begin in puberty. So the onset of menstruation is called. Goodness, phone is blowing up over here. The menarche, and then I'll say that occurs between ages 11 and 16 of years of age. With that being said, it's a changing time for a female. I cannot explain the feeling of that, obviously, but it's a time that things start to change. It can make them kind of uncomfortable to have certain conversations, especially with men. So if you have an issue with menstruation or significant heavy bleeding and they end up calling 911, if you have the ability to have a female attendant speak with the patient, it might be the best option. Or they may even feel uncomfortable talking about it with their parents being around. But if we're an all-male crew, we kind of really don't have an option with that. Women also continue to ovulate and menstruation until menopause, and menopause usually occurs around age 50. There we go. If fertilization does not occur within about 14 days of ovulation, the lining of the uterus then begins to separate, and the menstruation occurs for about a week. So the process of ovulation and menstruation is obviously controlled by the female hormones. Some causes of gynecologic emergencies are varied. There are a whole bunch that are out there we're going to be discussing. With that, they range from sexually transmitted diseases, STDs, to trauma. So pelvic inflammatory disease, otherwise known as PID, they called it, is an infection of the upper organs of the reproduction. So we have an infection of the uterus, ovaries, fallopian tubes, which occurs almost exclusively in sexually active women. So we have to ask that question, and especially when they're 15, 14 years old. Are you sexually active? You'll see extreme abdominal pain, most common sign and symptom would be lower abdominal pain. They also have like more of a pelvic pain as well, like hip pain. This can result in increased risk of ectopic pregnancy or sterility as well. The thing with PID is these patients require pain management, more than just giving them some Tylenol or ibuprofen. This is very, very painful for the female, and again, we have to find out if they've been sexually active or not. So that's why I was mentioning before, if we have a female patient that's underage, especially underage, where their parents don't know they're sexually active, we need to figure that kind of stuff out. So separating the patient from the parents, you may get some more information that's there that you're looking for. STDs can lead to more serious conditions such as PID, like chlamydia being one of them, which is the most common STD caused by a bacteria. Usually mild or absent symptoms, but can spread to the rectum and progress to PID. Bacterial vaginosis is the most common vaginal infection, where normal bacteria in the vagina are replaced by overgrowth of other bacteria. If untreated, it can progress to premature birth or low birth weight in pregnancy and PID. That's why it's very important to make sure that they're staying clean. Gonorrhea grows and multiplies rapidly in warm, moist areas of the reproductive tract. With this, there'd be the cervix, uterus, fallopian tubes in women, and the urethra in men and women. If untreated, it can enter the bloodstream and spread to other parts of the body. All right, this can cause significant fevers. This can alter mental status. Can get into sepsis depending on how bad the infection actually is. Needs to be treated with antibiotics. Bleeding males for vaginal bleeding. Bleeding may be considered menstrual bleeding also overlooked. So possible causes would be an abnormal menstruation, vaginal trauma, ectopic pregnancy, a spontaneous abortion, or cervical polyps or cancer. So again, if they're calling 911 for this, we're just going to transport them. If they have significant bleeding, we're just going to pad underneath and over so we can collect the blood, but they're going to need to go to the hospital and be evaluated by a physician. However, we also want to make sure they're not going into shock due to the increased blood loss. So this is where I'm going to ask the class really quick, see if anybody can answer. With that being said, what are the signs of shock, hypovolemic shock that we might see if the patient actually loses enough volume due to the vaginal bleeding, which can happen?
Fast heart rate.
All right, so tachycardia. What else?
Gray skin or pale skin.
Okay. Would you have blood pressure changes?
The blood pressure would drop, right?
It can eventually, yes. What about respiratory rate? Will that change at all?
Become more labored.
It can, and also you'll see tachypnea, right? Your body's trying to bring in that oxygen to help with the blood loss for shock and try to transport through the system, through the cellular level, because we're losing blood. Therefore, it causes the tachycardia to help move oxygen through to perfuse the tissues. When we start seeing shock, right, that's going to be the inadequate state of tissue perfusion, which is why we see tachycardia, tachypnea. But then we start getting into decompensated shock, we start seeing hypotension along with that as well. So we got to monitor these patients for shock. That's very important. Hold on 1 second, guys. So obtaining accurate and detailed assessment is definitely critical with the patient assessment. To be able to gain only a primary impression of the problem in the field. But throughout patient assessment, this will help you determine how sick the patient is and whether a life-saving measures are needed. So the patient assessment, remember, it needs to include your sample and OPQRST, vital signs, things like that. So we're looking at scene safety, BSI first. Remember, that needs to be ingrained in your heads for your national exam. Any testing station you go into, scene safety, BSI, and get that out of the way. Because remember, that's a critical skill and a critical fail. Gynecologic emergencies can involve large amounts of blood and bodily fluids. So we may have to actually protect ourselves if it's going to be significant blood, putting on a gown, safety glasses, protect our eyes, protect the mucous membranes. If the police are involved for a sexual assault or an assault is suspected, remember that it's important to have the female EMT provide care if possible. But again, if we don't have that, we don't have that. We have to do what we can. Remember that it is also a crime scene as well. We got to protect anything, blood on the clothing to blood on the floors. We're not going to be cleaning anything up. We got to bag the evidence that's there. We do not touch the vagina at all, especially if it's sexual type of an assault, because if there's any semen present at all, it's going to be done through the rape kits that are carried to the hospitals. And again, even in the ERs, the female nurses are the ones that usually handle those. Usually the male nurses don't even touch those at all. Usually they don't. So with that keep in mind, we got to make sure we're preserving the evidence that's there. We're looking at the mechanism of injury, which may be easily understood from the dispatch information, such as a sexual assault. But in other patients, patient history may reveal the nature of the actual conditions. You need to talk to your patients. You want to find out what's going on using your sample history. So allergies, medications, pertinent past medical history, last oral intake events leading to illness or injury. Then we get into our OPQRST, right, which is onset, what provokes it, quality, R radiation, S severity of 0 to 10 pain, and then T being how long has it been going on for time. So that's all going to be important information to gather when we have a patient that has been either assaulted and or it may have other conditions going on and we're trying to get more information about. We need a formal general impression. Is the patient stable or unstable? Are they sick or not sick? Can we see that by just looking at them? We're going to use the AVPU scale, looking at alert to verbal, painful, and unresponsive. We're going to look at airway and breathing, always evaluate first to ensure adequacy. Remember, if they don't have a patent airway or there's major bleeding, we can't move any further. We have to correct that. And then circulation, looking at pulse and skin color, temperature, moisture can also help identify blood loss. I believe it was Nancy that mentioned that earlier. Was it Nancy? I believe it was. I could be wrong. So we got to look at the skin. The skin's important to look at. Most gynecologic emergencies are not life-threatening. Okay, but if the patient has signs of shock, rapid transport is warranted. We need to have ALS on board, IVs established, and giving fluids if they're in shock to help replace some of that fluid loss. If they're in significant pain, we want to treat pain management. All right. So at the EMT level, you can give Tylenol. Okay, and yes, Maine too, because the new protocols went into effect today. So Maine EMTs have PO Tylenol, and you have PO Tylenol available as well for the EMT in New Hampshire. So with that being said, let's start treating these patients. Okay, let's try to reduce the pain that's there. Even if you give PO Tylenol, either state now, you can still call for a medic for narcotic pain management. It's still allowed to be able to give both. Okay, so if you think you need it, call for it. We're going to investigate the chief complaint looking at history taking. So some questions are extremely personal, but we have to ask those personal questions to make sure we have a good wraparound of what's actually going on. So ensure the patient's privacy and dignity are protected. All right, even if you have to ask a lot of the important questions in the back of the ambulance if the door is closed. For abdominal pain, ask about the onset, duration, quality, and radiation. That's the OPQRST. Provoking or relieving factors. What makes it better? What makes it worse? Then any kind of associated symptoms such as syncope, lightheadedness, nausea, vomiting, fever. You want to know about these questions here because if they have a significant infection, they could have nausea, vomiting. They're most likely going to have that fever. They're going to be lightheaded as well. So if we have that fever with tachycardia, tachypnea, okay, those are all signs and symptoms of shock. and also sepsis, right? So they could be septic because of that. And they may require other medications if they have low blood pressures, like fluids and other kind of vasopressors by the medics. So again, if you have these patients that have these types of symptoms, call for ALS to get ALS on board for these. For vaginal bleeding, ask about onset, duration, and the quantity. And again, you want to find out the number of sanitary pads that are soaked. How many have you gone through in the last 24 hours? How many have you gone through in the last hour? Associated symptoms such as syncope and lightheadedness as well during the history taken. Remember your sample history and note allergies and current medications. Ask about birth control pills or devices. Do they have IUDs in place? Do they receive a shot? Are they on the pill? We need to know this kind of stuff. Okay. Remember, sometimes birth control pills can also cause clots as well and PEs. So we need to figure out what they're on for medications. That's why the sample history is so important. And we also want to ask about the last menstrual period and any kind of potential for sexually transmitted diseases as well. Even if they are sexually active, you want to ask them, are you using protection? And if they say no, there's a higher chance for an STD, right? Last menstrual period. Let's see, now if they say, oh, it's been about, I'm 3 weeks late to a month late. Is there a potential that you could be pregnant? You got to ask the question. Pertinent secondary assessment findings should include vital signs, blood pressure, pulse, skin color, and orthostatic vitals. Orthostatic vital signs as they're laying down, sitting up, and standing. And we're trying to see if there's any kind of decrease in the pressures at all and heart rates going up. Looking at the abdomen, distension or tenderness. We got to palpate all 4 quadrants. Urinary, any kind of visible bleeding. Then we're also going to do a mental status exam. By doing so, we're going to ask them person, place, time, and event. Find out what their neurological status is. Are they altered or are they not? We're going to look at some physical examinations. Should be limited and professional. Protect women's privacy, so limit the number of personnel present as well. You don't need to have the fire department and EMS all in one room while a 16-year-old is having vaginal bleeding with 8 men and women standing in the room. It just gets very embarrassing. So get everybody out of the room and have a conversation with them one-on-one. Focus your assessment, your physical examination on the nature of illness and the patient's chief complaint with this. All right. So do a focus assessment. If there's any vaginal bleeding, visualize the bleeding and ask about the quantity and quality of the bleeding. Use external pads to control it, so you can use 5x9, things like that if you have them. If they have their own pads at home, they can utilize those as well. We just got to make sure we're collecting the blood. We're also going to ask about syncope, fever, nausea, and vomiting, which are significant signs of gynecologic emergencies as well. So look for those. Syncope being fainting. When we assess our vital signs, remember we're going to be doing vitals every 5 to 15 minutes. A lot of the new studies out there and literature that I've been reading in the past couple of weeks, they actually reduced it to 10 minutes versus 15. So as long as you use the 5 to 15 method in between those, you're pretty good, but they're trying to go to 10-minute vitals, even for that stable patient. We're going to look at heart rate, rhythm, and quality, respiratory rate, rhythm, and quality, skin color, temperature, and condition. We're looking at our cap refill time. What's normal for cap refill?
2 seconds.
Right, 2 seconds. And we got to consider doing orthostatics. So if you find the patient lying on the ground or lying on the couch, get a set of vital signs, right? If you're using auto BP after that, run an auto BP on them. Then when they sit up to get ready to go to the stair chair to move them outside if they can't walk, a set of vitals. As they stand up, it only takes an additional 3 to 4 minutes to do orthostatics. So if your patient's stable and they have syncope, let's get orthostatic pressures and see if they're having a volume issue. You're going to use pulse oximetry. You want to make sure that when you're using pulse oximetry that you have a good pleth. If you're using a cardiac monitor for that, you want to make sure you have good pleth marks, which I can go over with you guys on Sunday. You're going to consider non-invasive blood pressure monitoring to continuously track the patient's blood pressure. So if you don't have a monitoring device, if you're on like a BLS unit for, let's say, private EMS, where they don't give you cardiac monitors, all of our trucks up here for Action Ambulance have cardiac monitors where I work. But if you're on a truck that does not have one, then you have to do manual blood pressures every 5 minutes, right? Or 15, depending on stability of the patient. You're going to assess first blood pressure with a sphygmomanometer and a stethoscope. That's a long word for blood pressure cuff. I don't know why they just don't use blood pressure cuff. I'm going to use a stethoscope. Make sure you get your first one manual because that's the most accurate blood pressure you're going to get. We're going to repeat the primary assessment. Remember, there are very few interventions with gynecologic emergencies. We're going to transport promptly, and we're going to treat for hyperperfusion and shock, so hypovolemic shock. And then we're going to communicate and document everything that we do, including the possibility of pregnancy. And if it's a sexual assault case, you want to make sure you document everything in detail. Remember, this is probably going to be being subpoenaed and going to court. And you'll have to testify against your own report. We're going to maintain the patient's privacy as much as possible for emergency medical care. If in a public place, move to the ambulance. Okay? Do not keep them in the middle of a bank or the middle of a mall. All right, get them out of there, get them out of that area, and then get them to the back of the ambulance so you can do more of an assessment. If the female EMT, have the female EMT participate in the patient's care if possible. Again, if you don't have one, you got to treat it. Determining the cause of bleeding is less important than treating for shock and transporting. Right? If they're bleeding out, we need to start treating for shock, not what's actually causing the bleeding. It's not our job. Well, it kind of is, but not really. Again, treat the more serious conditions that you have in front of you. Most women will use sanitary pads to control bleeding before you even arrive. So again, when you get there, how many have you gone through? If you have, you may have to continue that approach as well. External genitals have a very rich nerve supply, so this makes injuries very painful. This is why I'm saying pain management. You can offer them Tylenol and start that process, but most of the time it's not going to touch it. They're going to need more of the heavy hitters like Dilaudid or morphine, fentanyl, some of the bigger stuff, ketamine, anything that can help with that kind of pain. We're going to treat external lacerations with moist sterile compresses. We're going to use local pressure to control the bleeding. You can use a diaper-type bandage to hold dressings in place if you have any on the ambulance. And do not pack or place dressings inside the vagina. So it's going to be on the outside to control bleeding. For pelvic inflammatory disease, when the patient with PID will complain about abdominal pain, a lot of times they'll have pelvic pain as well. This usually starts during or after menstruation and may be made worse by walking. They have significant pain. There's not much we're going to do in the field pre-hospitally for the EMT level. We can offer them some Tylenol for pain. That's about it. Non-emergency transport is usually recommended, though. Get them to the hospital so they can get treated. Get some antibiotics on board. Sexual assault and rape are common. 1 in 5 women has reported being raped, and 1 in 4 women will be sexually molested, based on statistical data. EMTs treating victims of sexual assault face many complex issues of this. So you may be the first person the victim has contact with after the encounter. So how you manage the situation may have a lasting effect on the patient and you as well. We got to treat these patients with the utmost respect. Professionalism, tactful kindness, and sensitivity are very important. You have to have empathy and sympathy for these patients that have been sexually assaulted. This can be male and or female. Does not matter which one. They can both be sexually assaulted. Document everything that is being said. Document everything that you've done for treatments. Again, if there is bloody clothes and we need to take clothes off and get them into a gown of some sort, if you carry gowns on your ambulance. So with that being said, everything has to be documented and bagged and labeled appropriately so that way they can be used as evidence for the case. If you have any kind of damage to the genitalia at all. Again, we have to treat any kind of major bleeding, but if there's no major bleeding, we want to make sure we try to leave that as untouched as possible. Be aware of drugs used to facilitate sexual assault or rape. So the ability to remember the event should create suspicion if they don't remember what happened. So could they have been given a date rape drug like ecstasy or something else like that? If these drugs are still in the patient's system, you may see hypotension, bradycardia, abdominal complaints, difficulty breathing, seizures, coma, and even death. All right, so we got to look past the fact that they've been sexually assaulted and look at the other signs and symptoms that are actually there if they don't remember a lot of what's going on and if they've been given a date rape type drug. All right, and if we can figure out what that is, we need to contact poison control for the treatments. You can generally expect police involvement. They're going to be there. So we're going to attempt to gather a detailed report from the victim because attempt to gather a detailed report from the victim may cause her to shut down. So if possible, give the option of being treated by a female EMT. If they shut down because due to the trauma of the incident, it's not going to help the case of trying to figure out what's going on. Right. So having that female present may actually help with that. Your focus should be provide medical treatment to the patient. Offer psychological care to the patient as well. Preserve any kind of evidence. Take history, and then produce a patient care report with that. So kind of treatment principles for the sexual assault itself, in addition to using usual treatment principles that apply to all victims, we need to follow these special steps in treating patients who have been sexually assaulted. So we're going to document the patient's history, assessment, treatment, and respond to treatment in detail because you may have to appear in court as long as 2 to 3 years later. Record only the facts and do not speculate what happened. Obtain a sample history. Follow any crime scene policy established by your system to protect the scene and potential evidence for police, particularly policies regarding evidence collection. If the patient will tolerate being wrapped in a sterile burn sheet, this may help investigations find any hair, fluid, or fibers from the alleged offender. Do not examine the genitalia unless there is major bleeding. If an object has been inserted into the vagina or rectum, do not attempt to remove it. Whenever possible, reduce the patient's anxiety by using an EMT of the same gender. Discourage the patient from bathing, voiding, or cleaning any wounds until after the hospital has completed an assessment. You want to handle the patient's clothing as little as possible, placing clothing in another evidence bag or paper bags. If the patient insists on urinating, ask the patient to do so in a sterile urine container if available. All ambulances are required to carry a urinary container, so have them urinate into that. Also deposit the toilet paper into the paper bag. Excuse me, and seal the bag, label it for law enforcement. This can be critical, important evidence. If possible, transport the patient to a hospital with specialized staff, such as a sexual assault nurse, what they call SANE nurses, who can fully evaluate these patients, perform medical and forensic examinations, and provide all aspects of medical and supportive care for these patients. I can tell you that if you're working in the area that I work in, Huggins Hospital has SANE nurses that are there. All right, so let's do a quick review. I want to hear back from everybody this time. So you can either type it in the text box or shout it out through the system. So what is the narrowest portion of the uterus? A, B, C, or D? All right, I've seen from 3 people so far out of the 8 that are online, or 9. Keep going. All right, the answer is actually B. So the ovaries are the primary reproductive systems. Developing embryo travels into the uterus through the fallopian tube. The embryo then attaches to the uterine wall and then continues to grow. The narrowest portion of the uterus is the cervix, which opens into the vagina. Remember I mentioned before how the cervix dilates during the end stages of delivery with that. All right, so number 2, what is the outermost cavity of a woman's reproductive system? The outermost. All right, the answer is C. Perfect. Number 3, if fertilization has not occurred within about how many days following ovulation? The lining of the uterus begins to separate and menstruation occurs. All right, D it is. Number 4, the onset of menstruation is called what? The answer is B, the menarche. Is the onset of menstruation typically occurring between ages 11 and 16? It really wasn't a good worded question. Number 5, which of the following can cause vaginal bleeding? A, B, C, or D? Right, D. Correct. Number 6, what is the most common presenting sign of PID? Correct. The answer is C. Number 7, so when obtaining a sample history, which of the following pieces of information is important to obtain? All right, we got D, correct. Number 8, so what is the EMT's first priority when dealing with a patient experiencing excessive vaginal bleeding? Bunch of mixed answers on this one here. Because the answer is B. So determining the cause of bleeding is less important than treating for shock and transporting the patient. EMT can control the bleeding by using sanitary pads on the external genitalia. When treating for shock, the EMT must place the patient in a position, keeping warm and applying oxygen. So this is one of those questions where there's 2 pretty close to being right answers. Which one's a higher priority? And for that would be shock treatment. Number 9, which of the following drugs is commonly used to facilitate sexual assault? A, that is correct. Number 10, you should discourage a rape or sexual assault victim from doing which of the following? All right, yes. D is the correct answer. All right, so we've been going at this for an hour. Why don't we take 10 minutes, come back, and we'll finish up with obstetrics and neonate. It'll take 10 minutes.
Kevin, I have a quick question.
All right, so we're going to cover chapter 33, obstetrics and neonatal care. So we covered a little bit of this in the pairs program we did 2 weeks ago. So that should help out a lot with the pediatric stuff, which we're doing next week with pediatrics, and then obviously obstetrics and neonatal care. All right. So this applies to special patient populations. So we're going to apply fundamental knowledge of growth, development, and aging and assessment findings to provide basic emergency care and transportation needs for a patient with special needs. So with obstetrics, we're going to recognize and management of normal deliveries, vaginal bleeding in the pregnant patient. We're going to look at A&P of a normal pregnancy, and then the pathophysiology and complications of pregnancy itself. We're going to cover the assessment of the pregnant patient, management of normal deliveries and abnormal deliveries, looking at nuchal cord, prolapse cord, and breech delivery. We're also going to do management of third trimester bleeding. We're going to talk about placenta previa and abruptio placenta. Spontaneous abortions, miscarriages, ectopic pregnancies, then preeclampsia and eclampsia. I also cover a little bit about neonatal care, and then I will cover New Hampshire protocol with that as well, and the neonatal care resuscitation. We'll talk a little about trauma and how we're going to treat the acutely injured patient, and looking at special considerations in trauma, recognizing and management of trauma in the pregnant patient, pathophysiology assessment and management of the trauma patient and pregnant patients as well. So most deliveries occur in a hospital. Occasionally, the pregnant woman is unable to get to the hospital, where this is where we get called in. So you must decide whether to either assist with the delivery on scene, or we're going to transport the patient to the hospital before delivery. And that's going to be based on what we're going to see on our initial assessment. Some A&P review really quick, obviously, with the female reproductive system includes ovaries, fallopian tubes, uterus, cervix, vagina, and breasts. And since we just covered all this stuff before, we can kind of go through this a little bit faster. Remember that the ovaries are two glands, one on each side of the uterus, and similar in function to the male testes. Each ovary contains thousands of follicles, and each follicle contains an egg. Ovulation occurs approximately 2 weeks prior to any kind of menstruation. The fallopian tube then extends out laterally from the uterus, with one tube associated with each ovary. With this being said, fertilization usually occurs when a sperm meets the egg inside the fallopian tube. The fertilized egg then continues to the uterus, where, if implantation occurs, it develops into an embryo and then a fetus, and then it grows until time of delivery. The uterus is a muscular organ that encloses and protects the developing fetus as it grows for approximately 9 months. So you can break that down into 3 different trimesters for every 3 months. This produces contractions during labor. This also helps push the fetus through the birth canal. Remember, and the birth canal is made up of the vagina and the lower third of the uterus called the cervix. That's where we start having dilation, is in the cervical dilation, as we can see here. So what will happen, as you can see baby in here, here's the fundus up top. This is the placenta that provides all the nutrients through the umbilical cord to the baby. This is the uterus here, it circles around. And this is the cervix right in here. This is where we start seeing, well, we're not going to see, they're going to be measured for dilation. The baby is encapsulated in this yellowish fluid you see here. That is the amniotic fluid in the amniotic sac. This is the sacrum of the spinal cord, located here. Rectum is located here, and the vaginal opening down here. This is the pubic symphysis. Underneath that, we have the urinary bladder. Above that right here as well. So obviously a lot of pressure on the bladder, which is why women pee a lot when they're pregnant, because pushing down on the bladder, causing urination. All right. This is a way that the baby should be positioned prior to being delivered. This is a normal delivery. We'll talk about placenta previa and abruptio placentae and what happens here with bleeding and covering of the walls and openings. So the vagina is the outermost cavity of the female reproductive system and forms the lower part of the birth canal. This completes the passageway from the uterus to the outside world. This is as it's coming out. Excuse me. The perineum is the area of skin located between the vagina and the anus. And that's where you'll have some tearing. So I go back to here. That's a bad picture. We'll find a better picture later on. The breast produce milk that is carried through small ducts to the nipple that provide nourishment to the newborn once it is born. Earliest signs of pregnancy in the breast include increased size and tenderness. Right? Breastfeeding can also help after delivery if the mother decides they want to breastfeed. It can also help reduce postpartum hemorrhaging as well. So that may be an option, as well as the fundal massages we'll talk about later on. The placenta attaches to the uterine wall and connects to the fetus by the umbilical cord. So fundus, placenta is located here. As you can see, all the nutrients through the placenta enter into the baby through the umbilical cord here, the fetus. The placental barrier consists of 2 layers of cells with this. Anything ingested by a pregnant woman has the potential to affect the fetus. So nutrients, oxygen, waste, carbon dioxide, other toxins that are out there, and medications as well. You got to keep that kind of stuff in mind when we're doing our assessments. We'll go more in detail in a little bit. After delivery, the placenta then separates from the uterus and then delivers. So the umbilical cord is the lifeline of the fetus. Again, this is very important. This is what gives them oxygen, nutrients, and everything else. The umbilical vein carries oxygenated blood from the placenta to the fetus. The umbilical arteries, 2 of them, carry deoxygenated blood from the fetus to the placenta. So as you can see, this is a little bit different than what we have in the normal system, right? So what do veins normally carry? Oxygenated or deoxygenated blood?
Deoxygenated.
Right, deoxygenated blood, right? In this case here, the arteries carry the deoxygenated blood. So in a umbilical cord, there's 1 vein and there's 2 arteries that are located in the umbilical cord. So the fetus develops inside a fluid-filled bag-like membrane called the amniotic sac. This contains about 500 to 1,000 mLs of amniotic fluid, which helps insulate and protect the fetus. All right. The fluid is then released in a gush when the sac ruptures, usually at the beginning of labor. All right. So there'll be, you notice a large amount of fluid, 1,000 mLs of fluid on the ground. Usually it leaks right out. There are occasions where they can still deliver with the baby still inside the amniotic sac. If you look on Google and type that in, you can actually see some of the photos of things of babies still in the amniotic sac as well, where it doesn't rupture before delivery. So normal changes in pregnancy, obviously many normal changes occur in the body that are not all directly related to reproductive system, respiratory, cardiovascular, and musculoskeletal. We start having respiratory changes because now we're putting a lot of pressure inside the thoracic cavity, right? Cardiovascular, now we're pumping for 2 at this point. So we got to keep that kind of stuff in mind as well. We also have the musculoskeletal changes, and as the hip and the pelvic area has changes as well to support that kind of weight, and then also for the delivery and help assist with that. Hormone levels start to increase. So to support fetal development and prepare for the body for childbirth, we start seeing increased hormones. As the fetus develops and grows, the uterus then also grows as well. As the size of the uterus increases, so does the amount of fluid it contains, and also the uterus and organs are then shifted from their normal position. Right, because it's got to make room for the fetus inside, so things start to change or to shift inside. We start seeing increased hormone levels. We have rapid uterine growth, which occurs during the 2nd trimester. So that's starting in month number 4. for 4 through 6, where we start seeing rapid uterine growth. As the uterus grows, it sends a push up in the diaphragm and then starts displacing the diaphragm. So as you can see, we start seeing some respiratory changes as well. So respiratory capacity then changes with increased respiratory rates and decreased minute volumes. Because now we have that thoracic cavity, the diaphragm starts moving and it starts becoming displaced to take up room for the fetus. And then our blood volume gradually increases. Remember, it has to allow for adequate perfusion of the uterus itself, plus having the amount of blood to support the actual mother. We also have to prepare for blood loss during childbirth as well, so it gives us some more blood flow. There's also the number of red blood cells also tends to increase as well. Remember that red blood cells also contain oxygen during the transport throughout the system to help perfusing. So also the speed of clotting also increases, and the patient's heart rate also increases up to 20%. So with all that added into it, we're going to start seeing changes in vital signs. In the third trimester, this is month 7 through 9, there is an increased risk of vomiting and potential aspiration following trauma. So due to the changes in gastrointestinal motility and the displacement of the stomach being coming upward. So we may have potential for vomiting, so we got to be careful for the aspiration to protect that airway if we have a trauma patient. We're going to have changes in the cardiovascular system and increased demands of supporting the fetus, increase the workload of the heart, so the heart's going to have to pump harder. Not all women are healthy when they begin pregnancy. Keep that in mind. So we need to obtain a good sample history. You got to get all the history behind it and find out what they were prior to this. Cardiac compromise is a life-threatening possibility with women that are pregnant, especially if they were not healthy prior to. We also have to consider drug use. What was it? Were they using drugs prior to pregnancy? Were they using drugs during pregnancy? Other questions to be asking as well is prenatal care. They've been receiving good prenatal care. They've been seeing the pediatricians for that to make sure that the prenatal care was done right. Then we'll talk about postnatal care when we get into neonates. Weight gain during pregnancy is normal. It's okay. The weight gain will challenge the heart also to impact the musculoskeletal system as well. So remember, we had that weight gain. Now it's putting more weight and more stress on the heart. And this will also impact the musculoskeletal system, where the joints then become looser or less stable. And we'll start seeing changes in the body center of gravity, which increase the risk of slips and falls. Because now remember, we have the fetus in the front causing us females to lean forward more, and it changes the center of gravity off, which then can cause traumatic falls. So complications of pregnancy, most pregnant women are healthy, but there are chances where they may become ill when they conceive or become ill during pregnancy. So use oxygen to treat any heart or lung disease in a pregnant patient. So give them O2, they need oxygen. Diabetes can develop during pregnancy in many women who have not had it previously. It's what they call gestational diabetes. And it usually resolves after delivery. So if you have a patient who's not feeling well, check a blood sugar, because the blood sugars could be low. Treatment is the same for any other patient with diabetes: diet, exercise, insulin injections. If the blood sugar is too high, they're going to need some fluids to help reduce that and dilute the system. So they're going to need to call for ALS. But again, even paramedics, we do not carry insulin in the ambulance. Hypertensive disorders, this is called preeclampsia in pregnancy-induced hypertension. This can develop after the 20th week of gestation. So signs would include severe hypertension, severe or persistent headache, visual abnormalities, swelling in the hands, feet, and anxiety. This preeclampsia can turn into eclamptic patients, and that's where you'll start seeing seizures with that. So eclampsia is characterized by seizures that occur as a result of the hypertension. These patients need magnesium sulfate administered, so you need to call for ALS paramedic. Provide not ALS AEMT. They need a paramedic on board for these, so they need to be given mag sulfate. So we're going to lie the patient on her left side. So why do we lie the patient on the left side? What is your thought process behind that?
It lowers their blood pressure.
Right, but why is it lowering their blood pressure? Let me rephrase. We really don't want
Because
to.
it's taking the pressure off the heart.
It's taking the pressure off a lot of the vital organs, and why we go to the left side. But if we have something called supine hypotensive syndrome, turning the patient to the left side takes it off that vena cava, correct? So we're not going to have that decreased blood pressure of the supine hypotensive. So we turn them on the left side to displace that fetus in the second trimester and above by pushing pressure. And there should be a picture coming up here shortly that I can show you guys what that looks like. We're going to lie the patient left side, maintain her airway. Remember we talked about second, third trimester vomiting. So you got to keep that in mind as well. If vomiting occurs, we're going to suction the airway and provide rapid transport and call for ALS care. We're going to transport the patient on her left side, which also can prevent supine hypotensive syndrome caused by compression of the descending aorta, inferior vena cava by uterus when the patient lies supine. So the baby actually applies pressure onto the vena cava. Nancy, I think you're still unmuted. So bleeding, obviously internal bleeding may be a sign of an ectopic pregnancy. As you can see in the fallopian tube here, we start seeing the fertilized egg start to develop inside the fallopian tube. And this can cause significant abdominal pain, and also the embryo develops outside the uterus, most often in the fallopian tube. This is the most common implementation of the egg outside of where it's supposed to be located. So if we have a female in childbearing years who is sexually active with an unexplained abdominal pain, it potentially could be an ectopic pregnancy. You can't rule that out.
Now, Kevin, is that more common too in like women that have like their tubes tied?
It can develop, but most of the time, I mean, it's not as common though. I haven't seen many of those. Most of them have been trying to find a blank here. Most of them have been like females that have not had who've not been too healthy. Those are the ones that I've seen those in mostly. Just trying to think of other times where I've seen this. I've seen it a lot in the younger kids more than I have in more of the older adults, like upper 20s to mid 30s. I've seen more ectopic pregnancies more in like the 18, 19, younger 20s, 21 years old.
Oh, okay.
That's when I've seen them. Again, it can happen to anybody, but that's where most of the ones that I've seen have been during that age group. In the last 20 years, I've been doing this job. So the leading cause of maternal death in the first trimester is internal hemorrhage following rupture of an ectopic pregnancy. So consider the possibility in a woman who has missed their menstrual cycle, it plays a sudden severe pain in the lower abdomen. So again, unexplained abdominal pain, but they have to be sexually active to have an ectopic pregnancy. So you want to be asking those specific questions. Have you been sexually active? Excuse me, are you on birth control? When was your last menstrual cycle? Hemorrhage from the vagina that occurs before labor begins may be very serious. Okay, it's not supposed to bleed. So if it's bleeding and significant bleeding, that's a problem. We gotta figure out why. There may be a sign of spontaneous abortion and/or a miscarriage. So an abruptio placenta, the placenta then separates prematurely from the wall of the uterus. So it separates from that, and with this, you're going to see very, very painful, bright red bleeding from the vaginal opening. So bright red. In a placenta previa, the placenta develops over and covers the cervix. If you have placenta previa, usually it's painless or very light pain, and it'll be a darker bleeding. But if you have significant, sharp, tearing abdominal pain, right, like sharp, sharp pain, 10 on 10, with bright red vaginal bleeding, it's 99% of the time it's going to be an abruptio placenta, where it separates, right? So in this one over here, you see the placenta is here and it starts hemorrhaging up top, right? This is more of your abruptio placenta. What will happen is this will tear, the placenta here will tear away from the wall, causing significant bleeding through the vaginal opening. Placenta previa, which is this one over here, it blocks the opening here, then causes more of a dark red bleeding and hemorrhage out. Right, so you're going to have to look at the blood and see what kind of blood it is. If it's dark and it's painless, but there's vaginal bleeding and they're pregnant, it could be a placenta previa versus abruptio placenta when it tears away from the wall. An abortion is the passage of the fetus in the placenta before 20 weeks. This may be induced or may be spontaneous. The most serious complications of these are bleeding and infection. So again, we're going to have to treat for shock as well and transport her promptly to the hospital. If you have a, go back one slide, sorry about that. If you have a spontaneous abortion, we want to take the fetus with us that spontaneously aborted. Okay, bring it to the hospital. Pregnant women have an increased chance of being victims of domestic violence and abuse. All right, so abuse increases the chance of spontaneous abortion, premature delivery, and obviously low birth weight. So again, we need to treat this like a crime scene. Same thing, right? Have they been sexually abused? Have they been physically abused? We need to treat these patients appropriately. Again, a female employee may be the best option for these, but if they don't have them, then we have to treat them as needed. The woman that is at risk from bleeding, infection, and uterine rupture. So we need to make sure we use a calm, professional approach, pay attention to the environment for any signs of abuse. Talk to the patient in a private area, away from the potential abuser if possible. If there's domestic violence, PDs should already be there before you go into the scene anyways. If they are not, request PD and have the potential abuser removed. Don't make it obvious to the point where you are accusing them of being an abuser, but just you want to get her away to be able to have a conversation. And even if that means getting her to the ambulance, say, right, we're going to start transporting now. We'll take good care of her for you. We'll see you at the hospital. Get her in the back of the truck, then start talking to the patient away from him or to find out what's going on, him or her. Substance abuse, the effects of addiction on the fetus include prematurity, low birth weight, severe respiratory distress, and death. And then fetal alcohol syndrome also describes the condition of infants born to women who have abused alcohol as well. We'll cover over that in neonates. We're going to pay special attention for substance abuse to your safety as well. So wear eye protection, face masks, and gloves at all times. Look for clues that you are dealing with an addicted patient. And remember, the newborn will probably need immediate resuscitation because they're probably not going to be breathing. So we'll talk about neonatal resuscitation here shortly. What clues can we look for in dealing with a patient that is addicted to drugs?
Would they have any needle marks?
Yeah, so those are called track marks. Yep. So we can look for track marks. What else?
Level of consciousness or level of awareness.
Okay, level of awareness. Are they altered a little bit?
Are they jittery?
All right, jittery. What kind of medications or drugs out there would cause patients to be a little more jittery and anxious? Common ones. I'm not asking you to go in detail for the ones that are not so common. More common stuff that would cause them to be like that. Yeah, Sean just said meth, so methamphetamines. Be one of those. What about vital signs? What is one thing you're going to look for that's pretty important when you have patients who are on under the influence of medications?
High blood pressure,
Yeah, that could be one of them. What else?
fast heart rate.
Tachycardia. We're missing one of the big important ones, though. Anybody else have any thoughts you want to add to the chat box or? Oops, sorry, Kelsey. I saw uppers. Sean said blood sugars. Yeah, we can definitely check blood sugars. We're missing one more vital sign assessment that's very important for anything with drug abuse.
Have you taken drugs?
Eyes. Eyes. Yep. Looking at the pupil response. Are they pinpoint? Are they dilated? That's going to be one of the biggest indicators when you have patients who are on either like methamphetamines versus sympathomimetics to patients that are on any kind of opiate narcotics. So we need to look at those. And you might see those patients that have meiosis, which are the dilated pupils. With a trauma call involving a pregnant woman, you have two patients. Remember that you have the unborn fetus and the patient itself, the woman. So trauma to a pregnant woman may have a direct effect on the fetus also as well. All right, so we got to pay close attention. Remember, we have two patients that are there. Now you don't have to call for two ambulances unless they deliver. All right, but we still have two patients we have to worry about. Okay, so what we do to the patient directly affects the uterus. I mean the fetus, not the uterus, the fetus. So the pregnant woman also may be a victim of assaults, motor vehicle crashes, and shootings as well. And the pregnant woman may also have an increased risk of falling. Uh, pregnant women have an increased amount of overall total blood volume and about 20% increase in heart rate. So if you have a pregnant woman with normal heart rates between 60 and 100, if it's at 110 or 120, that may be normal for them, and that's okay. What we would think would be tachycardia is actually normal for them due to the fact that they are pregnant. So we have to keep that in consideration when we're looking at our trauma assessments, looking for signs of shock. So uterus is also vulnerable to penetrating trauma and blunt injuries as well. You also may experience a significant amount of blood loss before you'll even see signs of shock because they have that additional blood volume to help support the fetus and the mother. So when a pregnant woman is involved in a motor vehicle crash, severe hemorrhage may occur from injuries to the uterus. And one of the leading causes in motor vehicle accidents is the abruptio placenta, where, remember, the placenta is then ripped from the wall, causing that significant abdominal pain, very painful bleeding, and bright red. The proper positioning of a seatbelt can also result in injury to a pregnant woman and also the fetus as well. So carefully assess the pregnant woman's abdomen and chest for seatbelt marks, bruising, and obvious trauma. This is why we have to expose our patients. We have to look at everything. If you see seatbelt marks, potentially there could be damaging to the fetus as well because the seatbelt may not have been sitting low enough on the pelvis. A lot of people wear the seatbelts up by the umbilical area, and technically it's supposed to be around the pelvis itself, not that high, to protect you from any kind of damage. Then obviously cardiac arrest. Your focus is the same as with other patients, CPR and transport. Notify the receiving facility personnel that you are en route with a pregnant trauma patient in cardiac arrest. Just because the mother has passed away does not mean that the baby is actually dead. All right. So doing CPR on these patients can actually keep that baby alive enough to get a C-section to have the baby removed. So again, I know normally, like in Maine, we have the protocol for traumatic arrest that we can just call it in the field. But again, if they're pregnant, we don't want to be calling that in the field. Even if the mother is dead, there's still an unborn fetus that's there that could still be alive. There we go. So follow these guidelines when treating a pregnant trauma patient. Maintain an open airway. Obviously, we got to keep oxygen flowing. Ensure adequate ventilation. If we have to ventilate, then we use a BVM. If not, we can apply a non-rebreather, a nasal cannula, whatever we need to do to maintain oxygen. But high flow is needed. We need to look at the non-rebreather for 10 to 15 liters per minute, and or using a BVM, giving them 100% oxygen. We're going to assess circulation, and we're going to looking at blood pressure, heart rate, and remember that for Maine and New Hampshire, we can also apply 12 leads now as EMTs. So it's not a bad idea to get an EKG if needed. We're going to transport the patient on her left side. That way there we take it all off the vital organs, and obviously the aorta and the vena cava as well, to allow for better blood flow, blood supply. Cultural sensitivity is also very important. So women of some cultures may have a value system that will affect the choice of how they care for themselves during pregnancy and how they have planned the childbirth process. So you need to understand that we're not going to, try to remember how to put this. We don't want to give them our views on their cultures. We need to respect the culture that they have and try to work with them the best we possibly can. Let me tell you this, okay, this is very important. Medical control will be your friend when you're on scene with patients with cultural sensitivity and trying to convince them to go to the hospital. I've only had a couple of these when I worked in more inner city stuff, and we called med control and we handed them the phone and let the patient talk to the physician. Sometimes that is the best option you can do, especially even up here. Same thing. If you're up in New Hampshire, Maine, you got people that have cultural sensitivity. I don't know, cultural sensitivity. Women of different culture that have different values. It may be a great option to have the physician actually talk with the patient over the phone. That's why my phone is always on me. I put it on speakerphone so I can at least hear the conversation. Remember, I am treating this patient still, and then let the physician try to convince the patient to go to the hospital. They may be more apt to listen to an emergency room doctor than it would be to a paramedic or an EMT. Some cultures may not permit a male healthcare provider to assess or examine a female patient. If this happens, respect these differences and honor the requests. So, a competent, rational adult has the right to refuse all or any part of your assessment or care. So you may have to call a mutual aid ambulance to get a female provider to come over. Teenage pregnancy. The United States has one of the highest teenage pregnancy rates. Pregnant teenagers may not know they are pregnant or may be in denial. So respect the teenager's privacy and assess and obtain her history away from her parents, because she may not want her parents to know that she is pregnant or she's been sexually active. Childbirth is seldom an unexpected event. It does happen, but seldom is it unexpected. But there are occasions when it becomes an emergency. So dispatchers usually ask simple questions to determine whether birth is imminent. The feeling for pushing, the length of contractions versus the time contractions are happening, they're all part of the EMD, or emergency medical dispatch process. Premature contractions may be caused by trauma and or medical conditions as well, where they start throwing contractions out that can be controlled. There's nothing in the back of the ambulance even a paramedic can do for the contraction stuff. We do carry Pitocin and oxytocin for this kind of stuff in MAG, but we are not permitted to give it for that situation. As far as scene size up goes, we're going to look for scene safety, BSI. We're going to take standard precautions. If there is actually a delivery, please put on a gown as well. It becomes very messy. Gloves and eye protection are a minimum if delivery is already begun or is complete. If time allowed, a gown should be also used. And gowns should be more readily available now than they were before, only because of the COVID stuff. Consider calling for additional resources. You cannot transport mom and baby on the same stretcher if you don't have the harnesses to be able to do so, if you don't carry those. All right? Everybody has to be secured in the back of an ambulance. You may have to call for a second truck. they come in. Looking at the MOI and NOI, you will encounter pregnant patients who are not in labor, so it is important to determine the mechanism of injury or nature of illness. Do not develop tunnel vision during this call, and falls and falls and necessity for spinal mobilization must also be considered. Just because the patient is pregnant does not mean that it's a pregnancy problem. Okay, it could just be a normal medical issue. It could also be a normal trauma issue, like a fractured ankle. All right, so don't get tunnel vision on the call and say, "Oh, well, you're pregnant. It's a fractured ankle. Let's stabilize the ankle, get her to the hospital for X-rays." All right, so you got to look at that kind of stuff. Don't get tunnel vision on the call. Look at everything that's going on. Look at the mechanism of injury, the nature of illness, and move forward from there. We're going to form a general impression. So the general impression should tell you whether the patient is in active labor or whether you have time to assess and address other possible life threats. We're going to perform a rapid examination, head to toe, and when the trauma or medical problems present, evaluate these first. So if they develop chest pain, put them on a 12 lead. If their blood sugars are low, we can give them oral glucose. We can treat this kind of stuff. Now, if they're saying that their contractions are lasting 30 seconds and they're 2 minutes apart, and she feels like she has to make a bowel movement, now let's focus more on the delivery at that point. If you open up the legs and you happen to notice crowning, be ready for childbirth. That's coming out. All right. So these are different things. Assess general impression, look what you have in front of you, and then make your determination on we're going to treat the medical problem, the trauma problem, or are we going to be delivering a baby? What's going to happen? Airway and breathing. So life-threatening conditions with the woman's airway and breathing are usually not an issue during a birth. But if it becomes an issue, we need to fix it. Motor vehicle crash, assault, or medical condition may also cause a life-threatening condition. We also talked about rupture placenta, which can be a life-threatening condition, both for the mother and for the fetus. So we're going to assess the airway, breathing, and to ensure that they are adequate. We're going to look at circulation. External and internal bleeding are potential life threats and should be assessed early. Blood loss after delivery is expected, but significant bleeding is not. So if we have to stop that, we're going to do what they call a fundal massage. We're going to push the pressure down on the fundus, and we're going to go into a counterclockwise position, rotation, and we're putting significant pressure down to control that bleeding. What we call a fundal massage. We're going to assess the skin for color, temperature, and moisture. We're going to check pulses. We're going to see if they're tachycardic, are they bradycardic, what is going on with the assessment. We're going to make a transport decision. If the delivery is imminent, prepare to deliver at the home. Do not do it in the back of the ambulance, right? The ideal place to deliver is either in the ambulance or at a woman's home. It's ideal, but the woman's home is usually the best place because there's more room to move. Delivery is not imminent. Prepare the patient for transport and notify them that you're coming in with a person, female in labor. Things to mention is know what your hospitals are capable of doing. If you work in the area that I'm working in currently, and I know some of you kind of work in that area already, find out which hospitals have labor and delivery. So for us, where I work, Memorial Hospital has it, and Frisbee. Those are my two closest ones, Rochester and North Conway. Huggins does not have labor and delivery. Lakes Region Hospital of Concord does not have labor and delivery. They have to go to Concord Hospital. All right. Wentworth Douglas has labor and delivery, and so does Portsmouth Hospital. But where we are, we have to either go north or south. Right. So know where you're transporting the patient. Now, if your patient's very unstable, motor vehicle accident, things like that, you might have to go to the closest hospital. Every emergency department can treat patients in labor. They can deliver babies in the emergency department, but they're not set up for longer term care. They don't have L&D units. They have to transfer out. So provide rapid transport for pregnant patients who have significant bleeding and pain. They are hypertensive, having a seizure, or have altered mental status. Remember, if they have altered mental status, check a blood sugar, right, as well. But also look at vital signs. Obtain a thorough obstetric history. What is her due date? Does she have a planned C-section? Do we have a date it's going to be coming out? or what is going to be her due date based upon a normal delivery, normal vaginal delivery. Any complications that she is aware of currently, a complete medical history, if she has been receiving any prenatal care, how many deliveries has she had so far? Because the more deliveries, the faster they come out. Obtain a sample history. Pertinent history should also include questions specifically related to prenatal care. Determining the due date, frequency of contractions, how often are they happening, and how long are they going for? History of previous pregnancies and deliveries. The possibility of multiple births, and if she has been taking any drugs or medications. Most of the time they know if it's going to be twins, triplets, quadruplets, whatever it may be. A lot of times they already know this, right? If you're going to have twins coming out, you probably need some more help. And keep in mind that most ambulances only carry one obstetric kit. So if you have twins coming out, you don't nearly have enough kits. Another one you want to ask too is if her water has broken, ask whether the fluid was green due to meconium staining. That's when the baby poops inside. Right? You start having that meconium staining, green staining. With that, you got to prepare for immediate suction because the baby's probably already aspirated the meconium. Physical examinations, we're going to assess the major body systems as needed, emphasis on the chief complaint. We're going to assess for fetal movement. So we're going to feel, make sure the baby is still kicking. We're also going to ask the mother when she felt the last time the fetus actually moved inside. If the patient is in labor, we're going to focus on the contractions and possible delivery. If there is contractions and they're 2 minutes apart, the OB kit should be out. And if you suspect that a delivery is imminent, we're going to open up the legs and we're going to check for crowning. If we see crowning, we're going to start prepping for delivery. We're going to look at vital signs. We're going to check the pulse, respirations, and skin color and temperature, and condition, and any blood pressure. Be especially alert for tachycardia and hypo or hypertension as well. Hypertension, even mild, may indicate more serious problems. So we got to make sure we're running vitals every 5 minutes. All right? Set the auto BP on every 5 minutes and monitor that. Don't just look away from it. Keep it in front of you where you can see it. We're going to repeat the primary assessment. We're going to obtain another set of vital signs, like I said, every 5 minutes. We're going to check interventions and treatments that we've already done. In most cases, childbirth is a natural process that does not require your assistance at all. It should be coming out head first. You should be able to have a good delivery, be able to place the baby on the mom's stomach. If they want to start breastfeeding, they can do so. After we've done suctioning and everything else to clear everything else, the baby starts crying. We use our APGAR score and everything else. We'll get into that here in a moment. And then the mother can take the baby. We can clamp the cord, we can cut the umbilical cord, and move forward and wait for the placenta to be delivered. The problem is when childbirth is complicated by trauma or any intervention you provide, the patient will benefit the fetus. All right, so ALS on board, getting paramedics there for you. We're going to communicate and document as well. If delivery is imminent, notify the staff of the receiving hospital. Hey, I'm coming in with an active delivery. Provide an update of the status of the woman and the newborn after delivery as well. Remember, after the first minute, we're going to get an APGAR score. If the delivery does not occur within 30 minutes, provide rapid transport. For a pregnant patient with a complaint unrelated to childbirth, be sure to include pregnancy status in your radio report. Let them know that you're in third trimester, number of weeks gestation. So we have 38 weeks, so we had 25 weeks. Where are we sitting? For due date and any known complications of the pregnancy that they know about. If delivery occurs in the field, you'll have 2 patient care reports to complete. Keep that in mind, because you have 2 different patients. So the stages of labor. We have the dilation of the cervix, which is stage 1, delivery of the fetus, stage 2, and delivery of the placenta is your stage 3. You're going to see this on your national registry exams. They hit pretty hard in labor and delivery and obstetrics. Because at the EMT level, this is probably one of the most common things for EMT to treat without having to call for ALS right off the bat. So the first stage, so stage 1, begins when the onset of the contractions ends and the cervix is now fully dilated. Fully dilated, we've seen usually like 9 to 11 to 12 centimeters dilated, usually fully dilated. Usually the longest stage lasting an average of 16 hours. Now, the more pregnancies that they've had in deliveries, the faster this process is going to happen. Uterine contractions become more regular. They last about 30 to 60 seconds each, and usually go in about 2-minute intervals. Frequency and intensity then starts to increase that they want to push and they want to bear down. Labor is generally longer in the premigravida, first pregnancy, than a multigravida, which is multiple pregnancies. Women may also experience preterm or false labor, which they call, or Braxton Hicks contractions. You should still provide transport for the patient either way, just to make sure. So false labor, Braxton Hicks contractions are not regular and do not increase in intensity or frequency, and contractions come and go, versus true labor, where contractions once started consistently get stronger and closer together. Pain and contractions start and stay at the lower abdomen, versus pain and contractions may start at the lower back and wrap around to the lower abdomen that way. Physical activity or change in a position may alleviate the pain or contractions, versus physical activity may intensify the contractions, and a change in position does not relieve any contractions at all. If there is a bloody show, if present, is brownish. Normally, the bloody show is pink or red and generally accompanied by mucus. If leakage or fluid occurs, it's usually urine. It will be in the small amounts and the smell of ammonia. In true labor, the amniotic sac may have just broken before the contraction started, or may break during contractions when a moderate amount of fluid that may smell sweet will present, and also fluid will continue to leak. So those are the differences between the Braxton Hicks or false labor versus an actual true labor. With the first stage also, some women may also experience a premature rupture of the amniotic sac, and then the patient may or may not go into labor or they need to provide supportive care and then transport the patient. The head of the fetus then descends into the woman's pelvis as soon as it positions for delivery. This descent is called lightning. When the second stage starts to begin, the fetus begins to encounter the birth canal, which ends when the newborn is actually born. That goes into the third stage when we start seeing the placenta delivery. Uterine contractions usually closer together and last a lot longer now. And excuse me, the perineum will then bulge significantly, and then the top of the fetus's head will appear at the vaginal opening. This is called crowning when you see this. This is what you want to see. You want to see that crowning. You don't want to see any kind of breach or a limb presentation. The third stage begins with the birth of the newborn, ends and with the delivery of the placenta. This can take up to 30 minutes, okay? Because the placenta must completely separate from the uterine wall. Please do not pull on the umbilical cord to get the placenta to come out faster. Consider delivery as at the scene when delivery is intimate or occur within a few minutes, a natural disaster, inclement weather, or environmental factors make it impossible to reach the hospital. Then we have to do a delivery on scene. We're going to determine if the delivery is imminent. Ask the patient, how long have you been pregnant? How many weeks gestation? When are you due? Is this your first baby? Are you having contractions? How far apart and how long do they last? Take out your watch or your stopwatch on your phone and time them. All right, we want to know how often they are occurring and how long they are occurring for. If they say, this is my 7th child, it's going to come out like a slip and slide. Be ready to go. It comes out fast. All right, so you got to be ready for it and prepare. Please do not drop the baby as they push out. Have you had any spotting or bleeding noted? Has your water broken yet? Do you feel as though you have the need to make a bowel movement? Do you feel the need to push? Were any of the previous deliveries by cesarean section? Normally, if they've had one C-section the first time, every other delivery after that is going to be a cesarean section delivery. Have you ever had problems in this or any previous pregnancies? Do you use drugs, drink alcohol, or take any meds? Is there a chance for multiple deliveries? Are you having twins? Does your physician expect any complications? This is one of the things about getting that prenatal care done, right? Making sure they've been giving imaging, they know where the baby is sitting, they understand what's going on. This is why it's so important to ask about prenatal care. If the patient says yes, or so if the patient says that she is about to deliver, she has to move her bowels or feels the need to push, you should prepare for delivery where you are. Does she have an extremely firm abdomen? Yes or no? Or visually inspect the vagina as well to check for any kind of crowding. Once labor has begun, it cannot be slowed or stopped. So never attempt to hold the patient's legs together. That's bad, right? Do not let her go to the bathroom. If she does and walks to the bathroom, the baby can deliver into the toilet. Do not try to push the baby back in because you're scared to deliver the baby, right? So let the baby deliver. Remember that if you deliver at scene, you are only assisting the woman with the delivery. We're not pulling the baby out. Let her do the work. Sometimes people want home deliveries, and they'll have midwives come to the homes. If there is a father present, or the father of the child present, and if they've gone through any kind of labor coaching or anything else, have them assist. It's perfectly fine. Your emergency vehicle should always be equipped with a sterile emergency obstetric kit, an OB kit. Every ambulance is required to have one on the truck. I'd recommend keeping 2. Let me go back a slide here. In your kit, obviously, you're going to have gowns. You're going to have the baby, the blankets. Sometimes they come with a little bit of blankets. They come with caps to keep the head warm as well for the baby. You're going to have clamps. You're going to have a scalpel to cut the umbilical. You're going to have a plastic bag, which is here. Okay. That plastic bag is for you to put the placenta in when it's all done. And we're going to deliver all that stuff to the hospital when we transport it. We're going to preserve the patient's privacy. We're going to place the patient on a firm surface padded with blankets, sheets, and towels. We're going to elevate the hips 2 to 4 inches. We're going to support the head, neck, and upper back, and we're going to have her keep her legs and hips flexed with her feet flat and her knees spread apart. We're going to place towels or sheets on the floor around the delivery area. We're going to open up our OB kit carefully. Remember, this has to be a sterile technique, so there's going to be sterile gloves inside. So for those of you who have sweaty hands, one of the best things to do with sterile gloves is put on your non-sterile gloves you have first, the ones you get from the box, and then take the sterile gloves and put them on over it. It helps slip on the other gloves a lot easier. We're going to use sterile sheets and drapes from the OB kit to make a sterile delivery field. Remember, it's open to infections. We have to make sure this is as clean as possible. As you can see here. So what you'll see, and I mentioned earlier about the tearing, as the cervix dilates and the head starts passing through the vaginal opening, you're going to see some bleeding here. Okay, what's going to happen is this is going to start making a tear down through to allow that opening to get bigger, to allow the head to start coming through. So now we're in the delivery phase. Your partner should be at the patient's head to comfort, soothe, and reassure. If the patient will allow it, apply oxygen. Continuously check for crowding. If you see it, prepare for delivery. Some patients experience preceptuous labor in birth. Also, position yourself so that you can see the perineal area at all times. You want to make sure that you can see everything. Last thing you want is to turn your head or sit someplace else. You don't have to stare at the vaginal opening and have the baby come right out as they make one push. So be ready. Time the patient's contractions. Remember, get your watch out and time them. How long have they been going on for, and how often are they apart? Remind the patient to take quick, short breaths, almost like panting, during each contraction, but not to strain. Between contractions, encourage the patient to rest and breathe deeply through her mouth. Right, something called Lehmann's breathing as well, to help out with that. Delivering the head. We're going to observe the head as it exits the vagina. We're going to support the head with your gloved hand as it rotates, okay? As the baby is rotating out. We're going to apply gentle pressure across the perineum with a sterile gauze pad to reduce the risk of perineal tearing. We're trying to do our best so it doesn't tear. Be prepared for the possibility of the patient to have a bowel movement, okay? They will most likely poop on you. Do not poke your fingers into the newborn's eyes or fontanelles. Be careful of the fontanelles as you're delivering. Those are your soft spots, okay? It gives you direct access to the brain. It can cause significant damage. Unruptured amniotic sac. If the amniotic sac does not rupture by the time the head is crowning, it will appear as a fluid sac emerging from the vagina. It will suffocate the fetus if not removed. So you may puncture the sac with a clamp or tear it by twisting between your fingers. Clear the newborn's mouth and nose immediately. Why do we clear the newborn's mouth before the nose? What are your thoughts?
So they don't swallow any of it?
Right. Because once you clear something, once you open either the mouth or nose first, they're going to take their first breath. Okay? Which is why we do the mouth first, so they don't aspirate it like you said, swallowing any in, and aspirate it into the lungs. Then we do the nose second. If we have a delivery where the umbilical cord is around the neck, as soon as the head is delivered, use one finger to feel whether the umbilical cord is wrapped around the neck. Usually you can slip the cord gently over the delivered head, but if not, you must cut it. Once the cord is cut, attempt a speedy delivery. Then delivering the body. So once the head is born, the body usually delivers pretty easily once the head is out. So we're going to support the head and the upper body as the shoulders deliver. We're not going to pull the fetus from the birth canal, let it deliver on its own. And the newborn, remember, will be very slippery and covered in vernix cassosa. Sorry. Hold on one second, guys. All right. So post-delivery care, if the mother is able and willing, place a newborn on her abdomen so skin-to-skin contact can begin immediately. We're going to dry the newborn and wrap him or her in a blanket or towel. Usually it comes with stuff that you need to wrap. We're going to wrap the newborn so the face is exposed only. Everything else will be covered up. There we go. You can pick up and cradle the newborn if you need to. If local protocols specify, keep the newborn at the level of the mother's vagina until the umbilical cord is cut. Always keep the head slightly downward to help prevent any kind of aspiration. So we're going to wipe the mouth with sterile gauze pads as needed, because there's going to be some more spit coming up, more fluids. We've got to make sure we're cleaning the infant as the neonate is born. Once the cord has stopped pulsating, we're going to clamp the cord and cut the cord. We're going to clamp and cut it. We're going to obtain the 1-minute APGAR score, which we'll cover here in a few minutes, and prepare for delivery of the placenta. Your job is to only assist. The placenta delivers by itself, usually within a few minutes of birth, but can take up to 30 minutes. Never pull on the end of the umbilical cord, okay? That'll cause tearing and more pain. So it's not going to come out unless it does it on its own. Please do not pull it out. You can help by slowing the bleeding by gently massaging a woman's abdomen with a firm circular kneading motion. It's a counterclockwise on the abdomen. That's what they call the fundal massage right about here. Take your palm of your hand, Push it down. He's using his fingers. Palm of the hand works best when a counterclockwise motion to help control any kind of vaginal bleeding. Record the time of birth in your patient care report, and the following are emergency situations. More than 30 minutes elapsed and the placenta is not delivered. There is more than 500 mLs of bleeding before delivery of the placenta. There is significant bleeding after delivery of the placenta. Call for ALS. We carry Pitocin for this, for postpartum hemorrhage, to help constrict the blood vessels. We're going to follow standard precautions for neonatal assessment. Always put on gloves before handling a newborn. We want to do our best to protect. Newborn will usually begin breathing spontaneously within 15 to 30 seconds after birth. And the heart rate will be at least 120 beats a minute or higher. That is normal for a newborn. Newborn ranges between when they're actually born, okay, till we start hitting the neonatal phase, which we'll cover here in a second. If you do not observe these responses, gently flick the soles of the feet or rub the back. This is called tactile stimulation. When you flick the soles of the feet, that can help spontaneously help them breathe and start getting responses. Many newborns require some form of stimulation, including positioning of the airway, drying, warming, suctioning, or tactile stimulation. So resuscitation for a newborn who is not breathing. The temperature, warm and dry, airway position and suction, breathing, stimulate to cry, circulation, heart rate, and skin color as well. We're going to look at basic life support interventions by drying and warming the newborn. We're going to clear the airway with a bulb syringe. Do not use your suction units. It's too much for them. Get a bulb syringe and suction out. We're going to stimulate the newborn if he or she is unresponsive. We're going to use a BVM to ventilate the newborn if needed. This is seldom required, but can happen. We're going to perform chest compressions if there is no pulse, or if the heart rate is less than 60 beats a minute after 30 seconds of ventilation, the heart rate is not increasing. Do not jump right to CPR, okay? Ventilate these patients. BVM, and then have to remember, use your neonatal pediatric BVMs, and we look for chest rise. Remember, it's not much air movement going in, right? So we got to be very careful how much air goes in so we don't pop these lungs. To maximize the effects of these measures, position the newborn on his or her back with the head down and the neck slightly extended. If necessary, suction the mouth and then the nose if needed. Remember, mouth first, nose second. Think of how the alphabet works too, M and N. So mouth first, nose second. In addition to drying the head, back, or body with dry towels, rub the back and flip or slap the soles of the feet to help with that stimulation, that tactile stimulation. We're going to observe the newborn for spontaneous respiration, skin color, and movement of the extremities. We're going to evaluate the heart rate at the base of the umbilical cord or brachial artery, or by listening to the newborn's chest with a stethoscope. The stethoscope is probably one of the best things you can do. Listen for heart sounds. The heart rate is the most important measure in determining the need for further resuscitation. If you ever take an NRP course as you move up in your ranks, you take a neonatal resuscitation course, everything's based on heart rate. So look at the heart rate. So more than 100 beats a minute. This is part of our neonatal resuscitation efforts. If the heart rate is more than 100 beats per minute, keep the baby warm and transport and assess the newborn continuously. If it's 60 to 100, we're going to begin assisted ventilations of the BVM at room air. We're not going to apply oxygen. Just help them breathe. We're going to reassess after 90 seconds, and if the heart rate respirations are not normal, then we start putting oxygen on. So initially it has to be at room air. Then it goes to 100% oxygen. Continue to reassess the patient, call for ALS backup if available, and keep the newborn warm. Right? If it's less than 60 beats a minute, we're going to begin with ventilations with 100% oxygen. We're going to reassess after every 90 seconds until a heart rate or respirations are normal. We're going to begin chest compressions, call for ALS if available. If the heart rate does not increase, medications are probably going to need, will be needed through ALS interventions. So you need to have a paramedic en route so we can start doing ALS interventions for the newborn. These things here on this slide, and I'll leave it up here for another second or two. These will be National Registry questions you're going to see. Because like I said before, labor and delivery is highly taught at the EMT level, and then it's touched upon as the advanced and paramedics go. Paramedics obviously a lot more in-depth assessment, but we move up the ranks. So you want to look at all the stuff we talked about is all BLS. So this is one slide you guys don't want to miss in your ebooks as well, is know what to do when you have the heartbeats between over 100, 60 to 100, and then fewer than 60 beats a minute, and how we're going to treat it. It's also in your protocol books as well by state on neonatal resuscitation efforts. If chest compressions are required, use the hand encircling technique for two-person resuscitation. Even with single person now with the new AHA standards, you can do the hand encircling technique now for a single person. Perform BVM ventilations and pause every third compression using a ratio of 3 to 1. 120 actions per minute, 90 compressions, and 30 ventilations per minute. This is completely different than what we teach you in AHA. Right? AHA, we look at 30 to 2, 15 to 2, right? Everybody should be saying yes. Got it. All right. With neonatal resuscitation, even based on protocol, looking at the New Hampshire protocols, it says 3 to 1. They want you to follow the neonatal resuscitation efforts for NRP. As you can see here, breathing, compressions. Any newborn that requires more than routine resuscitation requires transport to a hospital with a level 3 neonatal ICU. About 12 to 16% of deliveries are complicated by presence of meconium. So consider quickly suctioning the newborn's mouth and then nose after delivery before providing rescue ventilations. If you have a patient with meconium staining, you really want to get that paramedic on board because we have the ability to utilize meconium aspirators, utilizing intubation tubes and laryngoscopes to help suction this kind of stuff out. So again, call for ALS. All right, so the APGAR score, and this is, again, something else you're going to see on testing, and you're going to see this on your national. The standard scoring system used to assess a status of a newborn. They assign a number of value to 5 areas: appearance, pulse, grimace, or irritability, activity or muscle tone, and respirations. Right? We're going to do the first APGAR score after 1 minute. And then we're going to reassess the APGAR score 5 minutes after. This is stuff that has to be in your narrative. It also is questioning within your drop-downs for your PCR systems that you utilize. A perfect score is 10 that you can get. And here are your scores based on activity. So appearance, if the entire newborn is pink, they get a 2. They get a 1 if the body is pink but the hands and feet remain blue. And if the entire newborn is blue or pale, they get a 0. For pulses, more than 100, they get a 2. Fewer than 100, they get a 1. If there's no pulse, they get a 0. Grimace or irritability, if the newborn cries or tries to move the foot away from fingers snapped against the sole of the feet, they get a 2. The newborn gives a weak cry in response to stimulus, they get a 1. If the newborn does not cry or react to stimulus, they get a 0. Activity or muscle tone. Newborn resists attempts to straighten the hips or knees. Is a 2. 1 would be a newborn makes a weak attempt to resist straightening. The newborns don't want to be straight. They want to curl up into a ball. Newborn is completely limp with no muscle tone. They get a 0. Respiration, rapid respiration is a 2. Slow respiration is a 1. Absent respiration is a 0. And you have to do this 1 minute and then 5 minutes. We're going to calculate the APGAR score. Stimulation should result in immediate increase in respirations. So if you rub the back or flip the soles of the feet, we should see an increase in respiratory drive. If the newborn is breathing well, assess for a pulse. Check for a brachial. Or listen over the heart for heart sounds, and I should say, looking for heartbeats. Assess oxygen via pulse oximeter and observe for a central cyanosis. So central cyanosis being the core, being blue. The pulse oximeters that we carry in all of our cardiac monitors do not work for pediatrics or neonates. You have to take the Band-Aid style and connect it into your pulse oximetry system to make this work. Right? The ones we carry that are normally on these are meant for adults. Request a second unit if the newborn is in distress and require resuscitation. Right? Because remember, mom's still a patient there. In situations where assisted ventilation is required, use a newborn BVM. Ambulances do not carry newborn BVMs. Some might. I can't say not all of them. It's not a required deal on the checklist for the state. If the newborn does not begin breathing on his or own and does not have adequate heart rate, continue CPR and transport rapidly. All right. Excuse me. Any questions up to this point so far? Any questions at all? All right. I got Nancy saying good. Aaron, no. Everybody else good? All right.
I'm good.
Perfect. Let's move forward. All right. So breech delivery, something that we never want to see in the field. Most infants are born head first, but occasionally the buttocks are delivered first. This is called a breech presentation. Right? We do not want to deliver. These have to come out usually a cesarean section. These are immediate transports to the hospital. Breech deliveries usually take longer, so you'll often have time to transport the pregnant woman to the hospital. If the buttocks has passed through the vagina, the delivery has begun. Provide emergency care, call for ALS backup, and then consult medical direction to guide you. This is where you take your phone out, you put it on speakerphone, and you have the doctor on to have him guide you through the process. Or if you have a headset as well. But it's good to have it on speakerphone so everybody in the room can hear you on what's going on. But again, you can also carry your Bluetooth headset and have a conversation with the doctor, whether both their hands are free. Preparing for a breech delivery is the same as a normal childbirth. Position the patient, get the OB kit out, place yourself as you would normally. Allow the buttocks or legs to deliver spontaneously, supporting them with your hand. The head is almost always face down and should be allowed to deliver spontaneously. So make a V with your gloved fingers and position them in the vagina to keep the walls from compressing on the fetus's airway. This is one of the very few times where you can take your hands and place them inside the vagina, right, during a delivery. On rare occasions, though, you may have a single arm, leg, or foot. This is called a limb presentation. So a fetus with a limb presentation cannot be delivered in the field. This usually requires surgery as well. This is your C-section. We're going to transport immediately. If a limb is protruding, cover it with a sterile towel and do not try to push it back in. All right, we're going to place the patient on her back with her head down and pelvic elevated. If we have a prolapse of the umbilical cord, this must be treated in the hospital. The umbilical cord comes out of the vagina before the fetus does, as you can see down here. If this happens, the fetus's head will compress the cord and cut off circulation. We cannot push the cord back into the vagina, okay? So we're going to place the pregnant woman supine with the foot of the cot raised higher than the head. So remember, our cots do this, okay? This is Trendelenburg position, with the hips elevated and or the knee chest position. Insert your gloved hand into the vagina and push the fetus's head away from the umbilical cord and transport rapidly. Once you put your hand inside the vagina to lift them up off the cord, you're stuck there until you get to the hospital. So make sure you have extra manpower in the back of the ambulance to help you. Spina bifida, development defect in which a portion of the spinal cord or meninges may protrude outside the vertebrae. This is seen on the newborn's back. So we're going to cover the open area of the spinal cord with a sterile moist dressing. We're going to maintenance of the body temperature is also important when applying moist dressings. Keep in mind that these are very, very small babies, right? Even if they are fully developed and fully born at full gestational weeks, but they can get cold very fast. So they have such a small body surface area, so keep them warm. Multiple gestation. Twins occur once in every 30 births. Always be prepared for more than one resuscitation and call for assistance. Twins are smaller than single fetuses, and delivery is typically not difficult. About 10 minutes after the first birth, contractions will begin again, and the birth process will repeat itself. Second one usually born within 45 minutes after the first. The procedure is still the same as it would be for the single fetus, but remember there may only be one placenta or there may be two, depending on how it was developed. Record the time of birth for each twin separately, and twins may be so small that they look premature. Handle with care. Keep them warm. If there's a premature birth, so a normal full-time single newborn will weigh about 7 pounds at birth. Any newborn who delivers before 8 months, 36 weeks, or weighs less than 5 pounds at birth is considered premature. All right. A premature newborn is smaller, thinner, and the head is proportionally larger, as you can see in the picture right here. And the vertex cassosa will also be absent or minimal, and there'll be less body hair as well. So you'll notice full head of hair up here versus less body hair up here. Premature newborns require special care to survive, so often require resuscitation efforts, which should be performed unless it's physically impossible to do so. With such care, premature newborns as small as 1 pound have survived and developed normally. But they need to get to a neonatal or NICU unit where they can handle this. So in Maine, the closest NICU unit is Maine Medical Center. In New Hampshire, we have a couple that we can utilize. One being Dartmouth Hitchcock, and then what's the other one in Manchester? Can't drawing a blank. Not CMC, the Elliott. The Elliott Hospital also has a NICU unit as well. Pregnancies lasting longer than 42 weeks. This is a post-term pregnancy. Fetuses can be larger, sometimes weighing about 10 pounds or more. This can lead to problems with the woman and the fetus as well and be more difficult to deliver. These are the very large babies. It can cause significant tearing, a lot of pain. Other problems would be increased chance of injury to the fetus, increased likelihood of cesarean section. The woman is then at risk for perineal tears and infection. Post-term newborns have increased risk of meconium aspirations, infections, and being stillborns. And newborns may also not develop normally because it just took so long for them to come out. Fetal demise, you may have delivered a fetus who has died in the woman's uterus before labor. I have never had one of these, but again, it can happen. Onset of labor may be premature, but labor will progress normally in most cases. If the intrauterine infection causes the demise, you may note a foul odor as you're delivering. If they are obviously dead, do not attempt to resuscitate the neonate. Keep in mind, this also going to be very emotional time as well. So you're going to have to perform psychological first aid to the mother and to the family as well. And get people there to kind of assist you with that as well. You may also have to deliver a newborn without a sterile OB kit. It may happen. You should always have eye protection, gloves, and a mask with you. So carry out the delivery as if sterile supplies were available, and use freshly laundered sheets and towels. So if you're responding as a volunteer and you're responding to the scene, you get there first with your first in bag that you carry. You don't carry OB kits in your first in bags or on the ambulance. Your closest ambulance could be a half an hour out. If that's the case, you may have to deliver without a sterile environment. So do the best you can with what you have. Remember using clean sheets, towels, try to make your environment as sterile as possible. So you're going to wipe the inside of the newborn's mouth with your finger. Do not cut or clean up the umbilical cord in this case. As soon as the placenta delivers, wrap it up in a clean towel and transport. Keep the placenta and the newborn at the same level and keep the newborn warm. You got to warm these infants up, the newborns up. If bleeding continues after delivery of the placenta, continue to massage the uterus. Remember, frontal massage. Press down hard on the uterus, counterclockwise motion. Check your technique and hand placement if the bleeding continues. Excessive bleeding is usually caused by the uterine muscles not fully contracting. If it continues to bleed and bleed and bleed, this is where medics come into play and they can start giving oxytocin or pitocin for this. We're going to cover the vagina with a sterile pad. Change them as often as possible as you need it. Do not discard any blood-soaked pads. Right? Administer oxygen, vital signs every 5 minutes. We're going to monitor for shock and transport the patient immediately. Postpartum patients are at increased risk of an embolism, so clotting, most commonly a pulmonary embolus, resulting from a clot that travels through the bloodstream and becomes lodged in the pulmonary circulation. Consider this when a woman complains of sudden difficulty breathing or shortness of breath following delivery. If you see this happening, rapid transport. They need to get to an emergency room, and they're going to be going to an OR. Right? PEs will also be started with fibrinolytics as well, and thrombolytics to help remove the pulmonary embolus. All right, so to finish the night, then we'll go over a couple housekeeping things. And then for those who I've asked to stay on after the class is over, I need you guys to stay on. The first stage of labor ends when? A, B, C, or D? Let's get full class participation in this one. Everybody answer something. Remember, it's the first stage of labor ends when it ends, when stage 2 starts to begin. Correct answer is A. So let's go back really quick. So remember that the amniotic sac ruptures and labor pains begin. That's your first stage when it starts to begin, right? When we start seeing that baby come out, so we start seeing that crowning, right? And presenting part of the baby is visible. That's when stage 2 kicks in. So that's the end of stage 1. A 23-year-old woman who is 24 weeks pregnant with her first baby complains of edema to her hands, a headache, and visual disturbances. When you assess her vital signs, you note that her blood pressure is 160/94. She is most likely experiencing what emergency? I got a couple people answering, not everybody. Let's get everybody on here. All right, answer is B, preeclampsia. Remember that it changes to eclampsia when we start seeing seizures. You are transporting a woman who is 8 months pregnant. To prevent supine hypotensive syndrome, how should you position the patient? All right, D it is. Number 4, immediately after delivering the infant's head, you should The answer is D. Immediately following delivery of the infant's head, you should check the position of the umbilical cord to make sure it is not wrapped around the baby's neck, which is called a nuchal cord. If the nuchal cord is not present, suction the infant's mouth and nose. Number 5. So upon delivery, of the baby's head, you note that the umbilical cord is wrapped around its neck. You should do what? B. If the umbilical cord is wrapped around the baby's neck, nuchal cord, you should make one attempt to gently remove the cord from around the baby's neck. If this is not possible, the cord should be clamped and cut. Keep the cord moist, administer high flow O2, and transport at once. Number 6, the need for an extent of a newborn resuscitation is based on right. D is correct. Number 7, the 1-minute APGAR score of a newborn reveals the baby has a heart rate of 90, a pink body but blue hands, a rapid respirations. Baby cries when the soles of the feet are flicked and resists attempts to straighten the legs. You should assign an APGAR score of what? Anybody else want to add to this? The answer is C, 8. The most effective way to prevent cardiopulmonary arrest in a newborn is to all right, C it is. Number 9, while assisting a woman in labor, you visualize her vaginal area and see an arm protruding through the vagina. She tells you that she feels the urge to push. You should do what? Perfect. And number 10, the newborn is considered to be term if it is born after how many weeks and before how many weeks? Yeah, the answer is B, 37 to 42. All right, so let me discard this. Where's that? All right, so stop recording.